patient ventilator asynchrony refers to a mismatch between the patient inspiratory time, his neural inspiratory time, and the time of the ventilator, which is a mechanical breath. So there are two types of asynchrony: asynchrony of the time, which is called phase asynchrony, and asynchrony in flow, when the flow provided by the ventilator does not correspond to the need of the patient. So in terms of phase asynchrony, we distinguish the asynchrony when the ventilator starts later than the patient of the effort, or when the ventilator starts by itself. It's called auto-trigger. At the end of the breath, there is a premature termination of the mechanical breath, or delayed termination of the mechanical breath. And during the breath, there is not enough flow or too much flow, and this is called flow asynchrony. While the impact is not well understood. On the short term, of course, if we have a lot of asynchrony, the patient can be very uncomfortable, and then it impacts the tolerance of the treatment. So the most important is that when the patient wants to fall asleep with his NIV ventilator, that it's comfortable. If it's not comfortable, the patient will not tolerate. So this is very short-term view. Now, on long-term and on efficacy, honestly, we don't have any data showing that patients with high index of asynchrony have worse outcome than patients with less asynchrony. Well, it's impossible that the patient is totally well synchronized, 100%. So we have to accept some kind of asynchrony. I don't know how much is acceptable, and it's probably different according to patients. I mean, easy to ventilate patients such as COPD or obese patients, usually we target 80% of synchronization. Now, if we have more severe patients such as severe COPD or severe neuromuscular patients, then we accept a high level of asynchrony, and sometimes it's a goal to provide a mandatory breath, meaning to support the patient fully, which means 100% of asynchrony. Well, probably the most common is ineffective effort. So ineffective effort probably should be avoided as much as possible. The second one usually is double triggering. Double triggering is also very common, and it's very uncomfortable. So that's why we should try to avoid double triggering. Auto triggering is a third one. It's less common, less important, but still can be quite uncomfortable. So if we see some, we have to try to solve it. Well, most of the time, the first step is to look at leakages. If we have a lot of unintentional leaks, then this creates a lot of asynchrony. So the first step is to try to prevent and to correct leakages. Then the second step is to look at upper airway obstruction that per se creates some asynchrony. And the third step, if we don't have leakage and upper airway obstruction, is to adjust the ventilator settings, mainly the inspiratory trigger and the cycling criteria. Yeah, very recently there was a paper about PVA, which is great. It's published in Thorax this year, in 2019, and the first author is Jesus Gonzalez. So it's a group of experts that determine how to read the data from the software and how to classify the PVA. So it's a great paper, and I would suggest that you read the electronic supplemental material, which is very informative on this aspect.